Good afternoon, and welcome to today's presentation, Demystifying Patient and Family Engagement, Practical Advice on Engaging Your Patients in Their Care. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation. Please feel free to use the raise hand icon in your taskbar or submit questions and comments in the chat box provided. Today's presentation will include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our Health Visions Delmarva PCN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. We always start our webinars off with a review of our learning objectives. So today we are going to learn ways to improve patient and family health literacy and activation so that they become full partners in shared decision making regarding their own health and health care. We have 3 questions to run on. The first, how can I work to ensure that patients and families are really a part of the care team and committed to improving their own health? Second, how can I tell if my patients and families understand their medical condition and what they can do about it? And third, how do I evaluate the level of involvement, commitment, activation of my patients relative to their own health care? Today we are privileged to have with us Mary Minniti. Mary Minniti is a certified professional in healthcare quality and has over 30 years experience in the field. She has joined the Institute for Patient and Family-Centered Care in 2011 and works as a senior policy and program specialist. Mary worked for 16 years at Peace Health, an integrated healthcare system in the Pacific Northwest, where she served as the Quality Improvement Director for Peace Health Medical Group, a large multi-specialty practice. Mary's passion is bringing patients and family members into conversations about healthcare transformation because of the positive and powerful impact it creates for all involved. I would now like to hand it over to Mary to begin our presentation.
Great. Thanks so much. So everyone should be able to be seeing my screen. Let me minimize that. Sorry. So thank you so much for having me. I'm really excited to be here today. We are going to spend some time briefly talking about why patient and family engagement is so important, but most of the time we'll spend on spotlighting practical strategies related to shared decision-making, patient activation, and health literacy. And then we'll wrap up by having an opportunity to look at some of the TCPI tools and resources that are available to assist you in your practice as you implement or expand the strength of the patient and family engagement strategies that you have in place in your organization. In 2013, there was an entire health affairs journal focused just on patient engagement. And in this journal, they talked about a variety of ways to engage patients and families, but it was the first time that there had been kind of a universal or national definition of what patient and family engagement was. And they broadly defined it as an active partnership between individuals, their families, and healthcare clinicians and staff to do 2 things: to improve their health, but also the health of communities and the delivery of health care. Prior to that time, a number of people would often define patient engagement as whether or not the patient was complying with the treatment plan that had been ordered by the physician or the other healthcare professional. So what the realization in that year was that there were certainly things that we as healthcare professionals could do to influence patients and families, but ultimately it was the decisions that they made when they weren't in our office that made a big difference on the outcomes of their health and the cost to healthcare. And so it was very important to create that partnership model with them. And during that time, in the article that was really outlining the new definition for patient engagement, they really talked about a variety of levels at which patient and family engagement occurred. And today's webinar is all around the direct care level, although the articles and other articles since that time have also talked about the role of patients and families as partners in improvement of healthcare operations. But our focus really is on direct care. And if you look at the far right of your screen where it says partnerships and shared leadership, that really is kind of true north for patient and family engagement. That is that we really want to have a shared role with our patients and families in developing plans, in working toward improving health. That often healthcare has been at the left end of the continuum, which is we give information to patients and hope that things go well and that they understand that. But and as we move along that continuum, we begin to ask questions to really understand more about what motivates our patients. At the Institute for Patient and Family-Centered Care, we really always like to speak to why, although in the literature to abbreviate things, it's often patient engagement, but we like to remind our listeners that family is extremely important, however someone defines family. Maybe through a biological relationship, but maybe through an emotional relationship. But individuals who are most dependent on healthcare often are those that are very young, very old, or have chronic conditions. And quite frankly, their families are their allies for quality and safety and often are their cheerleaders and their supporters in making changes to lifestyles that can affect health. And so having them involved is really important. Many leaders in healthcare, including Don Berwick and Lucian Leap and Karen Clancy, talk about patients being essential and respected partners in their own care, and that family is respected as a part of the care team, and that mutual sharing in decision-making is really important. But one of the things that's also important to realize is that we get, and there is a recent study out by the National Academy of Medicine who looked at patient and family engagement in direct care and how that influenced outcomes and how that influenced staff. And what they identified was that patient and family engagement really creates a better culture, better care experiences, improves health, and reduced costs, all those things that you care about. And also, as members of the Transforming Clinical Practice Initiative, are things that you're working on. Returning joy to practice, reducing hospitalization, all of these things have been proven to be affected and improved by engaging patients and families in care. So there's a reason why there's an emphasis in TCPI on patient-centered systems, engaging patients and families. And in fact, last year, in December, well actually, yeah, in 2016 in December, CMS came out with a new strategic framework by which they were going to be putting kind of a frame or a lens on all of the programs that they funded and benefits that they provided, and it was all around person and family engagement cycle, and that they were going to look to encourage and incentivize practices and health hospital systems to really begin to engage patients and families meaningfully. And this is a place where the link to learn more about that. So the question then becomes, how do you build partnerships? And I would suggest that, and I learned this from a colleague, this is actually a picture of a doctor in northwestern Washington State who put his picture in an I Want You poster, and in a very small rural practice with 3 other physicians, and really engage them in both their care and in redesigning his practice. And it was built on an assumption that medical professionals have expertise, and that's a really important expertise to have, and that they can really partner with patients and families. But to also recognize that patients are experts on their own experience and that they have information that is helpful to you as a provider, as a healthcare team member, and that the family is the primary partner. So how you engage patients as well as their families is really important. So I want to tell you a story about my daughter, Jessie. Jessie was off to college and came home with quite a few ailments, and she'd been up to that time on the softball team in high school, had been very active, in good physical condition, but she came back and she was having a lot of distress. And so we took her to the doctor, who suggested that she go to a specialist because her father had celiac disease, and perhaps some of these symptoms that she was having were in fact related to perhaps she also had celiac. So at the age of 21, when she was able to drink beer and eat pizza with her friends legally, she instead went with her parents to visit with Dr. Andrew. Now, what really impressed me, because she wasn't kicking and screaming, but she was not exactly excited to find out, 1, that she had celiac disease, 2, that she had to change her lifestyle, and 3, that she had to go to an appointment with her parents. So, but when she went into not the exam room, but into Dr. Andrew's office, there were pictures of African animals, primarily their backsides, all over the office. And she looked at them and she started to laugh. And Dr. Andrews said, and he was decades older than her, he said, yes, I'm a photographer and I like to take pictures of things that interest me. And given that he was a gastroenterologist, things that interested in him were on the backside. So that began to create a rapport and break down some nervousness and barriers that Jessie had about what was this going to mean to her life, and what she had imagined living as a 21-year-old independent of her parents was going to be like. And as he began to chat with her, instead of telling her what she needed to do, he began to ask her questions about what was she most worried about as she was embarking on learning more about celiac disease, because she had a significant reaction to having wheat and gluten in her system. And she said the thing that she would miss the most, and this is often true when people are diagnosed with new chronic conditions, is they experience the losses of the things, the changed life that they had hoped for. And that was true of Jessie. And she said, I'm really disappointed I'm not going to be able to go out and drink with my friends. And he basically thought about that and said to her, oh, but you're going to be the really cool friend who drinks hard liquor with the little umbrellas in it rather than just beer, which everybody drinks. And so, again, he was trying to create rapport with her because changing her lifestyle was going to be very difficult. And what I would share with you is that Jessie only met with Dr. Andrew twice, once for that initial meeting and another time a year later when she came back and wanted to ask him questions about, did it really matter if occasionally she drank beer and ate pizza? And what he said was, every time you do that, you damage the inside of your body, and that's not a good thing, but it really is your choice. This is my daughter today. She's 36 years old. She owns a business, a gluten-free business, one of the few in Eugene, called Elegant Elephant. And she's holding her youngest daughter there, who also has celiac disease. But she has taken what many people would consider a negative in her life, really embraced it, and I believe because of the approach that the doctor took with her at a really impressionable age. He really thought of her as a partner on the care team, and that ultimately she would be making those decisions, and he respected her, and he listened to her, and he created opportunity for her to excel in that particular thing. And that really is something that is particularly important, especially, and I understand a number of you working with Delmarva are specialists. So often you don't necessarily have a long-term relationship with a patient, and you're making you're trying to make an impression in 1 or 2 or 3 visits as the person is kind of grappling with a new condition in their lives. And this is a particularly helpful article, and it's not particularly recent, but it is so important to understand that effective help giving is not just what kind of technical quality people have. certainly Dr. Andrew had a lot of technical quality. But it's the help givers' traits and attributes and how they are participatory in involving patients and families in that experience. And so there's a lot of good literature in addition to this about that. But I like this triangle because it really reminds us to create some balance in the ways that we connect with patients and families. And what we find out is when patients achieve common ground with physicians, their health status improves. Jessie was a great example, but there were many patients that Dr. Andrew, I'm sure, worked with, and other clinicians, including those of you on the call, and that there were fewer referrals and diagnostic tests needed when that connection really happens and information and shared expectations and goals are created. The other thing I want to mention is how important family presence is at medical appointments. Often in exam rooms there is the exam table and there's the doc's chair or the physician assistant or nurse practitioner's chair, and then there's an extra chair. And a colleague of mine, Dr. Bill Schwab, often says, is that the maybe if somebody shows up chair? How important is that? And he said it's really important to actively invite family members, whoever the patient chooses, to participate in ongoing meetings with docs and exams and things. And this Medicare study really compared the experience of patients who were accompanied by family members and those who were not. And there were lots of really positive outcomes that were observed in terms of facilitating communication, in terms of being highly satisfied with the patient, and really making that connection. Families can really be an ally for physicians and other care providers. So we wanted to talk a little bit about shared decision-making because when you come to common ground with patients and families in a shared decision-making process, and it very much is a process, it's not just telling patients and families what to do, you come to identify goals that patients and families can get excited about and develop some confidence about. And so it is a process, and sometimes there are ways that you can use decision aids and other techniques like TeachBack to really embed that goal setting in an active and effective way. So I want to stop for just a minute, and there's going to be a poll that Valencia is going to create. So Valencia, yes. I'm going to let you do that.
Yes. And ask, do you systematically record any of the following patient preferences in the medical record and check all that apply? Preferred language, preference for receiving information, who they would like involved in their medical care, hopes and goals for their health, or none of the above. We'll just give everyone a few seconds to respond. It looks like we have about 100% for preferred language, 80% preference for receiving information, 100% who they would like involved in their decisions, and 67% hopes and goals for their health.
Great.
All right, great.
So, Valencia, I'm assuming people can see my slides again. Is that true?
Yes, that's correct.
Okay, great. So, so there are a number of things that you can do on an individual level, patient by patient, that are related, and I think it's great that so many of you do request information about what's really important to patients and families. It's also really important to invite their participation. For many years, medical care was a very passive experience for patients and families. They came in, the doc or other healthcare professional kind of told them what to do. They went away, either did it well or didn't do it well, and hopefully came back to get additional encouragement or whatever about that. But and so sometimes it's very difficult for patients to move from that passive role to more active role. So your role in really asking questions, listening for answers, encouraging family presence, and also showing appreciation for their active participation is really important. And when we're doing shared decision making, it's important, although we as healthcare professionals may have a particular course of treatment we would really like a patient to choose, we need to recognize that there are often more than one option in terms of their choice. And sometimes an option is to do nothing based on values and preferences. But it's important to kind of understand where patients and families are coming from and invite their participation and appreciate what they have to offer about that. One of the things that really impacts engagement is health literacy, and how we invite patients in is really important. So health literacy is the degree to which individuals do two things. One, they obtain, process, and understand basic health information and services needed to make appropriate decisions, and how well they navigate the health care system. And what I would say is that most practices don't, on a systematic way, identify or assess health literacy needs. And so it is an important thing to do, because most patients will have some difficulty in comprehending health information and accessing health services. And this includes patients who may have college educations. Being literate and being able to read and write is not, it's certainly important and helps with health literacy, but it doesn't necessarily mean that they have confidence and ability to navigate the healthcare system or understand health information. So often it's recommended that you implement universal precautions, and I'll talk about some resources related to that. But often it's as easy in terms of understanding health literacy to ask patients just really simple questions about whether they understood their test results, or whether the medical words that I'm using are in plain language so that you can understand what's going on. I remember working with a care coordinator who was working with very challenged patients with diabetes, and one of the things that she was struggling with is that the patient was on insulin and she'd just come to be working with this patient. And the patient was saying, I am using my insulin. And she was just not understanding why the hemoglobin A1C was not showing any evidence of it going down. And so she asked the patient to describe to her what the person was doing when they were giving their shots. And the patient had had a demonstration using an orange by someone else in another practice who had used an orange to demonstrate how to use the syringe. And the patient began to describe what she was doing. And what she was doing is she was taking her insulin, measuring it out. She was shooting it into an orange, peeling the orange, and then eating the orange. And because obviously there was a disconnect in terms of what the patient was able to understand in terms of the information, even though she'd been demonstrated what that was. And so that was kind of a profound aha experience for that care coordinator about paying attention to having that kind of feedback from the patient, so that even though we think we're doing a great job, we may not. And what's interesting is that there was a study done by Blue Cross Blue Shield about the strong relationships that are built by continuity and connectedness, that is, if you're meeting with that patient on a regular basis, and that a well-informed patient is one who's comfortable asking questions, which you can create the environment to encourage those questions, as Dr. Andrew did. They become confident in making decisions, and they have explanations in ways that they can understand. And when people are given clear information, 8 in 10 will say that they want an equal role in their healthcare decision-making. And it was interesting in this study that they did in California among low-income patients, that the extent to which patients felt informed, that the information made sense, it predicted their engagement independently of more strongly or typical differences among population. So if you are providing to your patients, who probably are from a range of backgrounds and genders and socioeconomic statuses, information in ways that they can understand, it levels the healthcare playing field across population groups. So information is power. And so communicating via decision aids can assist you in helping increase the likelihood that patients are going to be able to understand that information and act on it. It says that 40 to 80% of medical information patients are told during office visits is immediately forgotten. But when you add decision aids, it helps patients be better informed and improves communication with doctors. And there are a number of decision aids for low cost or no cost available out there. And this one in particular through the Mayo Clinic is available and doesn't involve a lot of technology. So if you're a small practice, but it involves, and they've tested it with clinicians and patients in interactions, it really enhances the conversation, doesn't require any more time to provide some information, and is very helpful. So that's something that you can be thinking about. And I know in the TCPI project, they're talking a lot about reducing unnecessary tests, but how do you begin to have those conversations and provide that information to patients in ways that make sense? And so the Choosing Wisely campaign has, with the support of a number of professional associations and practices and specialties, has created a number of Choosing Wisely, both patient education materials and practice materials that help make sure that there are interactive materials that can assist in those important conversations about, is this test really needed? And so I just want to bring that to your attention. If it's not something that you've explored, it can be something that's very easy to implement with other team members in your practice. So I want to share with you another quick story, and then we'll move on. So this is a story about me. In June of 2016, I started to have a pain in my right foot. And I'm a walker. I've walked a number of marathons and half marathons. I may not be fast, but I'm steady. And I started to have extreme pain in my foot, and I'd had plantar fasciitis in the 90s. And so I knew how to do stretches and to take a leave on a regular basis. But after 2 months, that pain wasn't going away. So I went to my primary care doc and said I thought it was plantar fasciitis, and he recommended an orthotic and physical therapy, and I did all of those things, and in February of 2017, my pain was worse than ever. So he referred me to a podiatrist. And it's really important to understand what people really value. So I live on 48 acres, and I have a beautiful property, and in the spring it's particularly good. And in February I was really tired of not even being able to walk or stand at my standing desk. And so the podiatrist suggested that although surgery might be in my future, that the best thing to do was to quit walking totally and to wear some shoes that would elevate my heel, and to stop doing all the exercises that I'd been doing. Well, I had been working very hard at trying to improve my health related to my foot, and I was willing to do that, but I told him how important walking was to me and being outside, and he said, well, not for right now. And so I went back after a month, and I had improved a little bit. But this was what was happening on my property. Things were blooming, and I was wanting to go out. And he was asking me how I was doing on staying off my feet. And I said, well, basically, I'm pretty much staying off my feet and wearing those shoes 24/7, except when I take one walk once a week on my property, very slowly, to enjoy my wildflowers. And his response to me was, you're not being compliant with your treatment plan. And what I said to him is, I am being compliant with what I want to do to achieve a pain-free foot. But I also need to remember that I have to do something that's going to nourish me, because for almost a year I've not been able to do anything on my foot. And he listened, and what he did, which I thought was really great, was he created a short orthotic to put in my wet boots, because there was a lot of water on my property. But quite frankly, despite the fact that the first time I met with him, and I told him why it was so important to get back on my feet, he didn't really listen to what was really important to me. And he was more important, and most patients would have felt shamed by him saying I wasn't being compliant. But what I wanted him to understand is that a treatment plan is only a shared goal if it integrates patients' values and preferences. So I'm pain-free now, and he and I worked well together after he was able to understand that that one walk a week slowly was really important to my mental health. So how do you activate patients? That's a really important question because it affects how we create relationships with them. And activation really is a person's overall knowledge, skill, and confidence for self-management, because ultimately when they're out of your office, they are self-managing. One way you can do it is to spend some money and use the patient activation measure. And it's a wonderful outcomes measure, and many practices use it. But there are other ways to determine how somebody feels and their skills and knowledge and their ability to self-manage. One is to use a scale and ask these questions on a scale of 1 to 0, being how important is this to you, this change? How important is it to you, and why would you answer a 6 instead of a 7, and how much confidence do you have? And it's those probing questions that really help you understand what are going to be the barriers for somebody to follow through with their self-management. And when we pay attention to activation and support people in increasing their knowledge and skills and their confidence, it's really makes a difference. Another way to improve activation is through motivational interviewing. Motivational interviewing is really understanding and meeting people where they're at and helping them move from where they're at to where they'd like to be, small steps at a time, because oftentimes people may not have much confidence. People who've been overweight for a long time, if you're trying to help them reduce their BMI, or people who've had their diabetes and it's not been in good control, and they've tried lots of things. And so motivational interviewing is really important. That same care coordinator that I was talking with you about often would work with patients on developing shared goals, and she'd use motivational interviewing as an important communication technique. This is the ACP module practice advisor on how to learn more about motivational interviewing and set up some changes in your practice related to that. So I want to do another poll. Valencia, if you would be so kind.
Sure. Thank you, Mary. Our next question is, does your practice engage patients and families in selecting goals to improve their health and in development of a shared care plan? So you'll select one: rarely, sometimes, usually, or all the time. We're at about 50% that have voted. 75% have voted so far. Give it a couple more seconds. We have 22% rarely, 44% sometimes, 22% usually, and 11% all the time.
Great. So it sounds like people are across a continuum about that. And the thing that I would ask is when you indicate rarely or some of the time but not all of the time, I'd encourage you to think about what kinds of processes have you set up in your practice so that everyone on the team is really working on the development of a shared care plan. Because if it all falls to the physician, often with a limited amount of time in the office visit, that can be challenging. And so there are ways to work with your medical assistants and others to have them have a role in the development of a shared care plan. I want to tell you a story about Cambridge Health Alliance. Cambridge Health Alliance is out of Boston, and they have a number of clinics all over, some small, some larger. And they work with a very diverse at-risk population. And one of the things that they had not been doing is the development of shared care plans. And they realized when they were having the conversation with their docs and their teams that they were getting a lot of resistance to the idea of starting a process where they created care plans with patients and families. In fact, a number of clinicians said, we already have a plan for somebody. They've got diabetes, here's their plan. They've got this, here's their plan. This is what the evidence says that they could do. But what they also realized, and this is some feedback that they got from their care coordinators and their social workers, is that when they think about their patients' lives and the challenges that their patients have and the things that they're involved in, that often the office visit is just a small sliver of what happens in their entire lives. And so that they felt like it was really important because they had so many experiences where they share and give the care plan that they thought was the best for the patient to the patient, and then the patient would come back and nothing on the care plan had been acted on. And so they began to inquire as to what was getting in the way, and they began to see that perhaps it was important for them to begin to think about care plans in ways that were both health literate but also were doable for patients and families. And so they began to create with patients and families care plans that really talked about what were their health goals and what did they think would get in the way, and who's on their team besides the people at the clinic that were going to help them reach their goals. And over time they developed these care plans, and then they went from what are the goals to what are the activities that you might want to do, and how can you choose and look at the activation that patient might have. And they used graphics that were very common, that people could really understand and relate to. I talked about a ruler earlier on a scale of 0 to 10. Would it be a 10? But they, based on feedback they got from the patients, liked the red light, green light, yellow light better. And so this is an example of the care plans that they provided to patients after their conversation with patients and the development of goals. Now, this care plan didn't fit into their EMR, and so what they did is they had a way to create an area in the EMR where they could gather that information so that it was available to all members of the team, so that as patients called in or as they saw other members of the care team, maybe not the doctor in that particular visit, that they could access the health record and support the patient, find out how they were doing on their care team. And what I wanted to share with you is the impact that it had on the staff and the clinicians, because there was so much resistance when they started the process. And they began to say, hey, this is great. I love the action plan because it really helps patients create goals that they care about. People can focus on what's important to them. And then when I sit with the patient to do a care plan, the process of doing it really makes me stop and listen. So these are the kinds of things before and after. For those of you that are struggling with the development of care plans and how you're going to fit that into your busy day, what I would say we learned from Cambridge Health Alliance is the medical office assistants really worked with the patients and families on those first 2 care plans before the provider came into the room. So it was really a team goal to work in partnership with patients and families about that. The care coordinator that I was talking with you earlier about, when she was developing care plans, they weren't as fancy as this, and they wrote them on a less attractive piece of paper. But the thing I wanted to share about that with her is, when I was working with her, I would say, well, what kind of care plan did you come up with? And she said, well, I'm working with somebody who has diabetes, and their goal that they decided on was they eat probably 2 dozen donuts a week. I mean, that's just, they love their donuts. And so their care plan was really only to eat 2 donuts a day. And I said, they're never going to get where they need to go. And she reminded me that that was what they felt confident that they could do. And over time, I heard the story that, yeah, they only ate 2 donuts the first week, and then they were down to 1 donut a day, and then it was no donuts. And then she was trying to get them to become more active, and she started where they were at. Well, I think I can walk to the mailbox. And then pretty soon they were walking down the lane, because this was rural America where she worked, and they were losing weight and things, but they started with where they thought they could have some success, and it built their confidence. So the development of care plans is really meeting people where they're at and supporting them in having success. So I wanted to share another example of a practice change that a team met related to health literacy that was related to diabetes, because I know a number of you are working on diabetes. So they had an improvement aim. Maybe this is an improvement aim that you have. This is the Venice Family Clinic in California. They had wanted to increase their follow-up appointments for patients who had hemoglobin A1Cs above 9 because they were having a really poor show rate. And they were using traditional letters, and they sent reminders out in the patient portal, and they just didn't get a good response rate. So they put a small team together working with their PTN and a population coordinator, and they worked with the diabetes providers and got some feedback with them. They analyzed their current letter. They utilized this website as a resource to analyze what was the level that they were writing their letters at, and they found that they were above the 12th grade level, and realized that perhaps that might be why they're getting a pretty poor response rate. So they made some changes to the letter. They personalized the letter so that the patient got a letter that was addressed to them that actually was either in Spanish or English, depending on the patient's preferred language. And then they used a thermometer, and they were able to share with the patient where they were at on this thermometer. And obviously, being in the red or the orange was an area that was not ideal. And then the letter actually asked the patients to act, to call a particular person, and it was signed by the doc. And what they found out was they got a great response rate. And it was a very small test of change. They sent out 13 letters to the Spanish-speaking patients that they picked they had more than 13 that were over hemoglobin A1C9, but they wanted to do a small test, and the same number to patients who were English-speaking. And then they did a follow-up and called patients and asked them what they thought worked well about the letter and what they thought could be changed. And so you can read their comments on your own, but what they realized is that patients really loved these letters, that the letters connected with them in a way that the business letter that was all black and white didn't really connect with them. And so these were some quotes of what patients were saying about the letter. And I thought the first one was particularly well, because I think sometimes if you feel well, you think you're well. And clearly the letter communicated that maybe you aren't as well as you think and that there's opportunity for improvement, and then the patient was able to act on it. And they had a 39% increase in their response rate based on the small test of change, and so this is the way they send out their letters now. And they're beginning to modify this letter for other kinds of things like high blood pressure. And so this is an example of a great PDSA. So there are a number of things that you can do to improve what you're already doing, and based on the poll, it's amazing the kinds of things that you guys have been doing. I talked about the Health Literacy Universal Precautions Toolkit, and here's some information. What I love about this toolkit is there's a very short video that you can share with all of your staff so that they begin to see why health literacy is so important. Another tool is Teachback, and on the North Carolina site they have this great Teachback video showing how not to do Teachback and how to do Teachback effectively in ways that don't shame patients but really have patients feel like they're helping you by giving you feedback on how well you were able to communicate, and not feeling like, well, I guess I'm just dumb and so I'm just not going to speak up. Although oftentimes it's not our intent when we ask a question to patients to get an understanding of if they understood what we said or not. But this is a great video. Sometimes can really teach us really quickly what we need to do and how it would look. Another thing that people can do is they can use the CG caps for health literacy, and they have 31 supplemental questions. I'm not recommending you ask 31 questions, but go out and see the different questions that they ask, and then on a regular basis, just pick a couple questions that you just want to test the water temperature with your patients randomly on a couple days a month, just to see if you're kind of hitting the mark in terms of as you've implemented health literacy practices. So I want to ask one more polling question, and then I'll share some quick resources, and then we'll have some time for questions. Valencia?
Sure. Thank you, Mary. Our last question is, what actions do you take to improve your health literacy practices and understand how well the information you share is understood? Please select one. Use Teachback in all our clinical encounters. Train staff and clinicians about health literacy. Survey patients to ask for feedback on how well. Use plain language materials below 6th grade reading level. Provide multiple ways to share information on common topics. We have about 36% that have voted so far. A couple more seconds. About 64%. It looks as though we have 25% that survey patients to ask for feedback on how well. 13% use plain language materials below 6th grade reading level. And 63% provide multiple ways to share information on common topics.
Great. You can certainly use, I know this poll asked you to just mention one, but you can actually utilize all of those different ways to improve your health literacy practices. Start somewhere and then build on that, and I think that's great. So thank you for completing the poll. You're on your way. Many of you are on your way, and you're doing some great things, and you just want to continue to sustain those good practices, and as you learn from patients and families, to increase opportunities. One opportunity, if you were to look at involving patients and families in your practice improvements, is to have them review materials that you provide and share feedback with you about whether or not they raise questions, whether they're clearly able to be understood, and those kinds of things. So I want to share a couple person and family engagement resources that are available. On the Patient-Centered Primary Care Collaborative site, they're a SAN, a Support Alignment Network. Their focus is primarily on person and family engagement, and they have created materials to assist clinics if they decide that they want to begin to use patients and families as advisors. They have a number of resources and materials about the different metrics that you're reporting on. But the thing I think is a really good resource that they worked in collaboration with Plaintree on was 6 steps to create a culture of person and family engagement in healthcare. And the nice thing that it's got is really easy tools to work with your staff on to really embed person and family engagement as the way you do the work. And then, of course, in the TCPI program, there's resources for each of the performance metrics: health literacy, activation, shared decision-making, including more videos and websites and toolkits that you may find useful. I've mentioned a couple, but just a couple in this webinar, and there's more out there that may be better suited to your practice. I also want to encourage you, if you want to join our learning community, it doesn't cost anything. It's called PFCC, Patient Family Centered Care Connect, and it's an online learning community, and we have a special topics group or network of TCPI practices that are doing primary and ambulatory care, and they surface questions to each other and answer questions and share different things that they're doing. This site is being transitioned to a new platform, and so check it out after the 15th of November, and you'll see a site that looks just like this. So I'm going to stop now. We've got a few minutes for questions, and Valencia and Cindy, I think you guys are going to moderate the questions, so I'm going to take my slides down so that I can see the questions.
Yes, I don't see that we have any questions as of yet. Cindy actually has a question.
So, Mary, first of all, I want to thank you again on behalf of our group and our PTN for presenting this today. I think it's so important that we be thinking about how we incorporate patient and family engagement in everything that we do. And it's not like a separate project and a separate focus, right? It's an umbrella going over everything that we do, because after all, everything that we're trying to improve through transformation has to do with improving the care for our patients and improving the care for the population that we serve. So who better to ask and to engage than our patients and families to try to understand what will work best for them. So again, I just want to thank you. But I did have a question. I love the idea of just those 2 questions to assess activation. One on confidence, their confidence in being able to succeed, and one in the importance of the issue that they were working on. If you were looking at like the CAPS questions, for those of our practices who aren't using that formal survey, who might want to incorporate a couple of questions into their normal either satisfaction survey process or into just into their day-to-day operations to ask people as they come in for appointments, where would you suggest we start? Which 2 questions would you suggest that we ask to try to drill down on that health literacy need?
So one that I think is a good one that is particularly helpful is, and it has to do with safety. The provider gave easy to understand instructions about taking medicines. And you can change that question if it isn't the provider that's giving those instructions, but you have a care coordinator giving those instructions or a pharmacist or whatever. That might be a really good question, because that really relates to safety and it relates to efficacy. Often we find that patients related to medication management don't get their prescriptions refilled, they don't take the medications as directed, and that's a particular one. And then whether or not the patient felt like the provider encouraged them to discuss their health questions or concerns. And again, you can change, whether it's the provider or someone else, but what you're trying to get at is, have you created an environment where somebody felt free to ask questions and share their concerns? Because it's often when we don't create that environment, where we're so rushed that we don't create that environment, that that patients leave with their concerns unanswered, and so they don't really act on the information that has been shared in the meeting. But there are many more questions that are out there, and I think that often one of the things that's a good approach as you're looking at health literacy kinds of things is to have the staff watch the video that's out on the Universal Precautions site. It's 6 minutes. You can even give the link to people and ask them to watch it. They don't have to all watch it together. And then pull up those questions from the CAPS survey site and identify which questions the group wants to get feedback on, that they're going to take action based on how people respond. And then if you have a checkout process, try to make it simple. What is your current habit and process that you use? And try to see how you could fit in asking 1 or 2 questions. Some groups use texting, where after a patient has had because a lot of people, they might not have smartphones, but most people have cell phones, and most people have texting. And so sometimes a group that I know of sends out a health literacy question, simple to ask, and people just answer yes or no or whatever, by hitting 1 for this or 1 for that. And then it goes to them like three hours after their appointment. And that's a way for them to just have it be kind of automated. And they found it very helpful. And then the staff together work on, well, what can we do to improve the score on that? How can we help? And then if somebody really didn't understand at all and, their answer would, they have a process by which somebody calls that person and reaches out.
Okay. I love the idea of using the checkout process because a lot of our practices have that process in place. So it would be easy to incorporate. Thanks, Mary.
And thank you, Mary. We have a comment that says, thank you very much for this presentation. They thought that many practices think that the PFE is just having a routine patient survey. Now we have more resources to use to fully engage with our patients and provide the best care to those we serve. So we definitely can benefit from this, and we appreciate the personal reflection that you shared as well from your family experiences and the websites that you shared with the MayoClinic.org with the weight change and the shared decision, as well as the PFCC Connect information. So this full presentation will be loaded to the website so that everyone can benefit from that. So we definitely thank you.
Well, let me just say one thing, and that is I covered a lot of territory fairly quick, and what I want you to know is that change in small increments is the way to go, even for practices, not just for patients. So if there was one idea that you thought made sense, try it with one patient and see how it went and get some feedback. I worked with a colleague, a family practice doc, who she was getting ready to change a form, and they didn't have an advisory council, but as people came in to see her, she would say, we're trying to improve this form so that it's more understandable. Could you review it on your way out and then just leave your comments with the receptionist? I'd really appreciate it. Now, people that were really sick, she didn't ask them to do that, but people who were coming in for preventative and early, not so acute, awful sick, gave her all kinds of feedback so that she could improve that. And so even with your teach back, try it with one person. See how it goes. Try the scale of on a 0 to 10 scale or the red light, green light with one patient and see how it goes, and build some confidence and some experience, and then expand as they did at the Venice Family Clinic, where they tried something just for one, for a small group to see if it made a difference and help them move closer to what their goals were for improvement. Because, Cindy, you made a really good point. This is not new or different work. This is the way we do the work. So if you're trying to improve something, include some of your patient and family engagement principles in that. The Venice Family Clinic didn't even think about health literacy before they heard a presentation about it. And so then as they were trying to improve that, they went, well, what can we learn more about health literacy so that we can make sure that our efforts make a difference? And so start small, celebrate your learning, and stick with it, because patients and families really want to work in partnership with you.
Great. Thank you, Mary. And moving forward, we have our next upcoming webinar. We want everyone to save the date for Cat G's Guide to Alternative Payment Models webinar, which is going to be on November 16th at 5 o'clock p.m., and you'll receive more information about that. And we also have our Health Visions Delmar Routine contact list here. If you have questions, if you want to reach out to any of the practice advisors, here are their names, email addresses, and their telephone numbers for contact. And this information will also be included on the website for today's presentation. And we thank everyone for participating, and if you have any other questions, please feel free to reach out, and everyone have a good day.
Thanks so much. Bye-bye.